Okay, and welcome to the Davies Use Case webinar being presented by Cleveland Clinic Abu Dhabi on VTE order and optimization. This is the Davies Award-winning use case for the value of health IT. My name is Arnold Simmons, and I'm the Manager of Quality and Patient Safety here at HIMSS. It's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. It's my pleasure to welcome our speakers for today's webinar. Dr. Iqbal Banaj, Tori Mahmood, Vijay Kolar, and David Grinnell. We would like to thank you for joining us today, and you can begin when you are ready. Thank you so much.
Hi, my name is Iqbal Banoj. I'm an attending physician here at Cleveland Clinic Abu Dhabi. I practice hospital medicine, and I also oversee the internship and residency education activities here at Cleveland Clinic Abu Dhabi. I'm also being closely involved in quality improvement projects, one of which is the VTE prophylaxis ordering optimization project, which we started here at CCAD, and which is one of the case studies that is about to be presented. Before I begin, I wish to give an overview of Cleveland Clinic Abu Dhabi and who we are. The leadership of Abu Dhabi has identified healthcare as a key element of the vision for future development of the country. And Cleveland Clinic Abu Dhabi has partnered with global leaders and Muadala's network of world-class assets to lay the foundation of a sustainable healthcare system. Our aim is to create a virtuous circle, helping people to lead healthier lives and having a full range of resources when they need critical and complex care. Our mission, which is our very foundation of existence, goes beyond providing complex and critical care for the population. We are committed to supporting medical research and education and also providing a venue for Emirati nationals to develop their careers in the healthcare sector in both clinical and non-clinical roles. So in order to fulfill our mission, we work from this incredible facility that we find ourselves in today, which is the Cleveland Clinic Abu Dhabi. Our hospital was designed to offer state-of-the-art treatment for some of our community's sickest members. The center occupies a gross area of 23 acres in site. We are being served by 26 operating rooms with a capacity of 364 beds, both acute care and critical care, and it is expandable up to 496 beds so that in future we continue to grow to meet the local needs of a community. That also includes the diagnostic treatment centers of 16 procedure rooms, imaging suites of which are 17 and 41 room emergency department as well. So in order to provide this complex and critical care at Cleveland Clinic Abu Dhabi, our focus is on excellence in patient care and supporting medical research and education. The Clinic Abu Dhabi is a physician-led hospital, and it has a unique multidisciplinary model of care. And this model of care we aim to provide closer to home for our patients, ensuring that they do not need to travel. We are organized around 13 institutes, including 5 centers of excellence, which are the Heart and Vascular Institute, Neurology Institute, the Digestive Disease Institute, Eye Institute, and Respiratory and Critical Care Institutes. These institutes combine to offer complex and critical care across more than 30 medical and surgical subspecialties and more than 60 subspecialties. Working together, we provide an unparalleled level of care for our local and regional communities. There are more than 5,000 caregivers working at the hospital, representing more than 17 nationalities. It is this incredibly diverse caregiver family that also reflects the diversity of the UAE population. Our efforts to support the development of the next generation of Emirati caregivers have led to a recent success in growing the number of UAE national caregivers to 18% of our workforce. In addition to the world-class care that we provide, Cleveland Clinic has a number of unique offerings. We have a raft of detailed outcomes and performance metrics that are continuously monitored at the highest levels of our organization. Patient experience is a key part of that. We pride ourselves on delivering a world-class experience from the moment our patients enter our hospital until they leave. Our guiding principle is patients first, a philosophy which guides everything we do. This enables us to focus on delivering exceptional levels of complex and critical care and supporting people for every step of the patient journey. Innovation is at the heart of our care as we introduce new treatments, devices, technologies, and approaches to our care. That innovation extends beyond our hospital as we work with Mubadala to create an integrated healthcare network between the Mubadala assets, supporting the full provision of care as a national health service. Our patients' first approach to care combines state-of-the-art amenities with the best global clinical practices. Every aspect of the whole hospital was designed with the patient in mind. Our Office of Patient Experience that reports directly to our CEO provides direct oversight at the highest levels. We have extremely tight integration with our main campus in the United States with regular video conferencing for physicians to collaborate on cases. We have built the world's first globally integrated healthcare network. When a patient comes to us, they have access to 57,000 highly skilled medical experts around the world. There are three factors that make a facility like this possible: the support of the nation's leadership, which we have, the need within the community, which we are addressing, and a strong partnership, which is what we have with Mubadala. Collaboration. Since day one, planning the site and set up together. Now we are working with Mubadala to create an integrated healthcare network between the Mubadala assets, supporting the full provision of care as a national health service. We are a leader in terms of the quality and complexity of the care, from advanced regional first treatments like the first robotic mitral valve repairs to bronchial thermoplasties, remote heart monitoring, as well as 24/7 epilepsy monitoring. Fulfilling our promise to deliver world-class healthcare in the UAE, including the development of the multi-organ transplant program, including the first heart transplant, first liver transplant, first lung transplant, more than 11 kidney transplants happening in the UAE since our inception. So UAE's first robotic hysterectomy, first robotic myomectomy, first endoscopic sleeve gastroplasty, and cardiodyne mitral valve repair are all a first for the region. In our role as an academic teaching hospital, we provide a foundation for the future development of the UAE's medical sector, allowing the next generation of UAE national physicians to train and develop their skills. We continue to expand that role, launching a residency program, physician internships, and preparing to offer our first fellowships. There are currently 55 academic research projects running at the hospital as of 2018. We have expanded our services to include launching a Cleveland Clinic Al Ain region in 2018, new outreach programs to Northern Emirates, and we are looking at more opportunities to grow moving forward. And we also, one of our key expansions will be the introduction of oncology treatments in 2019. Now, as I head into the case study that we are going to present, which is the VTE optimization project here at Cleveland Clinic Abu Dhabi, I'll give a little background on how this came about. At CCAD, when it opened in 2015, we had a set of workflows for assessing VTE risk and prophylaxis measures, which were based on templates brought from the Cleveland Clinic main campus in Cleveland, Ohio. The thinking and rationale is that if it's a tried and tested product from our over a 100-year organization, then it is likely to work here. We began operations in April 2015 with capturing of data since then as we implemented those templates. But as we came up with the data, we found interesting challenges. CCAD is unique in that the physicians and caregivers are from over 160 countries, and they have come together to provide care in this one institution. They come from diverse cultural backgrounds, following various guidelines from various continents, in fact, Europe, Asia, Canada, North America, etc. And many have never even come across certain guidelines that are being implemented for VTE prophylaxis measures. So one of the key quick things we realized was that we needed to standardize our guidelines, develop a culture of applying a single workflow, and we had to figure out a way that was the best practice guideline for the region and for the patients that we serve. So our main criteria was an inadequate compliance that was noted on the data that we also received on measuring these metrics, and our compliance measures in 2015 were 85% in terms of administration of VTE prophylaxis in eligible patients. So we had to set a goal of improving our VTE prophylaxis measures, including assessing the risk for patients, capturing the DVT at-risk patients, ordering the appropriate VTE prophylaxis, and adequate and compliance with administration to reach an internal target KPI of greater than 95% compliance. To attain these goals, we had to create tools to facilitate VTE risk assessment. We had to update VTE orders to align with current evidence-based guidelines. We had to refine best practice advisories to optimally support clinical decision-making. We had to update nursing flow sheet to ensure discrete documentation of patient refusal and create discrete documentation to flow into data, abstract, or reports. One of the other outcomes we had to look at was to decrease the post-operative PE DVT rates based on the mandated Abu Dhabi Department of Health quality requirements. So in terms of guidelines, because of the diversity of how caregivers have provided VTE prophylaxis measures across various countries, we had to try and go through the guidelines and standardize it. And the key guidelines we looked at were the antithrombotic guidelines released by the American College of Chest Physicians, commonly known as the 89 guidelines in 2012. We used the Agency for Healthcare Research and Quality Project guidelines for our quality improvement measures. We also reviewed the National Institute for Healthcare and Excellence guidelines from the United Kingdom to see if some of their guidelines could be incorporated into our VTE prophylaxis guidelines. To create, design, and implement this optimization project, we had to create a stakeholder group which comprised the VTE prophylaxis optimization team. It was a very multidisciplinary, diverse group of caregivers who came together. The physicians included myself as the physician lead for the VTE project with key inputs from various subspecialties, as this impacted various institutes and various subspecialty levels of care in the hospital for inpatients. The stakeholders included clinical and nursing teams who were the frontline providers for these implementation strategies, including nursing education, the pharmacy. We did have personnel from the Quality and Patient Safety Institute with the involvement of our institute chair, our clinical risk managers, clinical data abstractors. We had nursing quality managers, and of course, none could be done without the key and crucial input of the IT and EMR team, including the clinical documentation analysts, inpatient orders analysts, and informatists, which include the inpatient informatists and inpatient trainers. So once we started identifying what were the key areas to improve, our informaticists were involved in creating the solution for improving the project.
At a high level, these were the IT solutions identified and implemented. We'll talk more details about this in the next few slides with details of IT build. Risk assessment tools have been added. VTE orders were updated to align with current evidence-based guidelines. VTE modules have been added. Assessment and reassessment BPS were refined. Nursing vascular flow sheets have been modified to document discrete documentation. Abstractor reports were updated. At a very high level, we'll talk about the timelines. During design and build phase from November 2016 to February 2017, IT team worked with interdisciplinary stakeholders to make build changes for the requirements to best practice advisories, VTE risk assessment, prophylaxis order sets, impacted admission order sets, flow sheets, and rules. Implementation was done last week of Feb. From March, after implementing these changes, you can see the compliance rate improving, which will be explained in detail by Tori. During optimization phase, incidents and requirement changes were addressed during this phase in March and April. Enhancements and maintenance phase. During this phase, we addressed some of the enhancement features available with Epic upgrades such as cascaded order sets. Reassessment BPA triggering time were reduced from 168 hours to 72 hours, and VTE BPA trigger times was changed from 12 hours to 24 hours. VTE prophylaxis order set mobilization success section was updated to default certain orders like mobilized patient with early ambulation as tolerated. Flow sheets were updated to include additional rows for documentation. Workflow. In the workflow diagram, all yellow highlighted boxes have build associated items which were built and tested by IT teams. Patient can get admitted from OR areas, home, clinics, other hospitals. We updated all impacted admission order sets to include the VTE module in the order sets. 24 hours post-admission, VTE BPA triggers if the requirements are not met. 72 hours post-admission, reassessment BPA triggers to ensure requirements for prophylaxis orders and applying mechanical are met. After physician places order, nurse acknowledges these VTE orders. If patient refuses, nurses documents and the message is triggered to physicians in basket. If patient doesn't refuse, nurse administers and or applies mechanical and updates the nursing flow sheet. These are the different order sets which were modified to include the VTE module within these order sets. So at a high level, this is the VTE module with the links to Padua and Caprini.
And to further emphasize on how these risk assessments were done, we looked at the guidelines on what are risk assessment models that have been extensively validated in medical studies, and we identified the Padua Medical Risk Assessment Calculator for medical at-risk patients to be identified, and the Caprini Surgical Risk Assessment Calculator for surgical patients, non-orthopedic. Again, these were clinical decision support tools that were created within the order set to have the physicians be able to make an informed critical decision on what would be the appropriate risk to be assigned for a patient that is admitted to the hospital. These links lead to the actual scoring system where various medical comorbidities are assigned here as through the Padua scoring, and that allows for a point-based scoring, 0 to 3 points being lower risk, 4 to 20 points being higher risk of having symptomatic VTE in the medical at-risk patient. This is an example of the Padua scoring for medical. The next slide shows the Caprini risk assessment model for general surgical patients, particularly mentioned non-orthopedic general surgical patients. And again, a point-based scoring system identifying level of risk being very low risk, moderate risk, and high risk. So this solution designed for VTE risk assessment and prophylaxis included a cascading order set.
Yeah, the cascade, you can see the features of the cascading order set, like when VTE risk category high risk surgery is selected, the following subsections get highlighted. So upon selecting the next one, like pharmacological prophylaxis, then the appropriate sections get displayed for pharmacological. And similarly for the VTE mechanical, selecting VTE mechanical prophylaxis will allow the physician to choose the appropriate choices like intermittent pneumatic compression or graduated compression stocking. This is some features like the cascaded order set features were utilized. So this is, we're going to talk about the VTE, some of the criteria that were used to build the VTE1, and VTE1 will fire under the following criteria. Patient must be 18 years of age, patient is on acute floor and currently admitted, patient does not have a diagnosis of ischemic stroke, patient does not have a contraindication indicated, patient does not have any active med prophylaxis order, nor has patient received an administration of the said order. Patient does not have documentation in flow sheets of application of mechanical prophylaxis. Patient does not have an active order for mechanical prophylaxis. Patient has been admitted for at least 24 hours. VTE1 also does not fire in the ED, only fires for physicians and residents. So VTE, reminder, VTE will fire every 72 hours for the following criteria. Patient must be 18 years of age. Patient does not have documentation in flow sheets of application of mechanical prophylaxis. Patient does not have an active med prophylaxis order. Patient has either of these following core measure orders. Patient does not have an active order for mechanical prophylaxis. And similar to the above one, VTE reminder does not fire in the ED and only fires for physicians and residents. And this is the nursing flow sheet where the nurse documents the discrete values if the mechanical was applied on the left, right, bilateral, or any of these choices. And this is the message that the physician will get in their in-basket when the nurse documents patient refusal.
So based on these implementations, we were able to capture data from how our interventions have shown the compliance to VTE prophylaxis measures. Tori Mahmood has been a key part of our data analytics team throughout this entire process, and I'll hand over to Tori to talk in detail about the slide that is shown right now.
When we began abstracting the VTE measures, we identified that we could not seem to break greater than 90% when we had an internal target of 95% compliance or greater. So for the first, from quarter 4 2015 through quarter 4 2016, we had a mean compliance rate of 86%. In quarter 4 2016, I began working with the VTE core measure champion, Dr. Iqbal, as well as the team which he outlined. And we implemented intervention in the late February 2017. And we began seeing results starting with quarter 2 2017, where upon that point forward, we began to have a mean compliance rate of 93%.
So the value derived from what we see in terms of the compliance improvement, we saw, first of all, ordering efficiency improved by physicians. By creating risk assessment model as clinical decision support tools, implementing cascading physician ordering systems, introduction of BPA algorithms to allow for reminder for BPA assessment firing, we were able to achieve an increase in our compliance rate to what Tori has mentioned. The implementation of the physician in-basket communication, the nursing flow sheets, reduced the gaps in communication between the physicians, nursing, and pharmacy caregivers in relation to the VTE prophylaxis ordering system. The revised BPA algorithms led to less intrusion on physician daily workflow when it comes to risk assessments for longer length of stay patients without compromising patient safety. The anecdotal feedback that we have been receiving has been very high physician satisfaction in terms of the ordering of VTE prophylaxis measures because of the less time needed to order and the ease of documentation of the VTE prophylaxis measures. Again, the work remains to be improved on. It is a continuous improvement project as we continue to capture data on our compliance measures, We are receiving feedback from the physician frontline caregivers and the nursing caregivers on how better to improve the process. We are working on optimizing nursing documentation. We are expanding the capturing of PE, DVT outcome measures, reporting for all inpatients. We are broadening education to the key stakeholders, including nursing, physicians, pharmacy, factoring in the diversity of our caregiver workforce here at Cleveland Clinic Abu Dhabi. We are in the process of developing education materials for the patients to engage them in having a better understanding about what is venous thromboembolism and what are the measures that are being put into place while they are hospitalized for VTE prophylaxis, and also trying to reduce a rate of patients refusing prophylaxis measures despite adequate education. We continue to improve on the process on the analysis of our care delivery for VTE prophylaxis measures. So to recap, we were able to identify inadequate compliance with the evidence-based assessment, ordering, and administration of VTE prophylaxis in eligible inpatients. We identified solutions, we created a design and implementation whereby the VTE workflow was streamlined and automated for admissions and transfers. We had VTE order set modifications, BPA algorithm creation, improving flowsheet documentation, which all resulted in an improved VTE compliance rate that was consistently meeting the internal target of 95%. We also improved the clinician workflow for VTE ordering and documentation, and we contributed to reducing the PE DVT occurrences. All this would not have been possible without the key input from various multidisciplinary teams. Particular mention our application analyst from the IT team, Vijay Kolar. He was responsible for providing system build solutions, workflow analysis, and troubleshooting support related to EPIC modules, inpatient orders, and inpatient clinical documentation in collaboration with multiple disciplinary teams. Our key data abstractor, Tori Mahmood, who was responsible for review of patient records and abstracting, aggregating and analyzing process and outcome measures for outside reporting agencies and internal stakeholders. And the names are quite a lot, and these are just some of the few, but I have to thank everyone here within the Cleveland Clinic Abu Dhabi VTE optimization project who have engaged and have clearly influenced how we have come about to improve our VTE ordering prophylaxis system here at Cleveland Clinic Abu Dhabi. Thank you.
Okay, we would like to thank our speakers from Cleveland Clinic Abu Dhabi for joining us today. And we would like to remind our listeners where to go find Davies use case webinars and information on how to apply for Davies. That information can be found posted at the HIMSS Davies Award website at hims.org/Davies. That is hims.org/Davies. Thank you for joining us.